Hi, everyone. Thank you so much for joining me today. So I'm Eugenia Shmidt. I'm an IBD physician at the University of Minnesota. I have a special interest in fertility, sexual function, and pregnancy. And I have a multidisciplinary clinic committed to preconception and pregnancy counseling in women who have IBD. And so I'll be speaking to you about fertility and pregnancy in IBD. All right, so the objectives of this talk are to discuss the impact that IBD and IBD-related surgery may have on fertility specifically. I will emphasize the importance of multidisciplinary preconception care. We'll talk about what to expect in pregnancy and how to prevent flares and manage disease during pregnancy. This is advancing. And then we'll also talk about delivery, breastfeeding, and infant care. And it's a pretty small group today, so we'll take advantage of that. And I welcome you to actually interrupt me and ask any questions that you might have. So you chose to come to this session, so I don't have to, emphasize to you why this topic is so important. But the point here is that the diagnosis of IBD occurs mostly during childbearing years. So more than half of patients who are diagnosed with IBD get the diagnosis before the age of 35. And that's exactly when family planning and sexual identity are being formed. So it's especially important to talk to our patients about reproductive health, because we know that you're making these decisions in the context of IBD. We know that many people have fears that drive voluntary childlessness, meaning many people with IBD, they decide not to become parents because of certain things that they're afraid of related to their disease. So the most common causes of fear are thinking that IBD itself may harm the baby. They fear that IBD medications can cause harm to the baby. They think that maybe they can't get pregnant in the first place. They're worried about passing the disease onto their baby. And my goal is to educate you about whether or not these fears are founded, and for you to make an informed decision about what works for you. All right, so we'll start with fertility. So first we'll start with an overview of how infertility is defined in the general population. So according to the WHO, the World Health Organization, infertility is defined as failure to become pregnant after 12 months of regular unprotected sexual intercourse. And so generally this affects about 6 to 15% of the general population. And the biggest risk factor in the general population is age, meaning it carries the greatest weight in predicting someone's ability to become pregnant. And when I say someone, I mean females. And so when it comes to IBD, that actually remains to be true. So age is a much greater factor when it comes to infertility. So as Dr. Party mentioned earlier, there are certain surgeries that occur in the setting of IBD. And we know that pouch surgery, which is done for patients with ulcerative colitis, has the greatest impact on fertility. So essentially, pouch surgery involves rectal dissection, meaning removing the rectum. And next to the rectum, there are fallopian tubes. And so when there is dissection in the rectal area, that can lead to significant scar tissue in the neighborhood. And the fallopian tubes live in that neighborhood. And so we do know that patients who undergo this pouch surgery with an open technique have about a 3-fold increased risk of infertility compared to those who don't undergo pouch surgery at all or rectal dissection at all. The good news is that it seems that less invasive technique, a laparoscopic technique, can help reduce that scar tissue. And we also know that it can lead to shorter time to pregnancy and can lower infertility risk. Although that infertility risk is not gone and is still significant even with a laparoscopic technique. So this is a summary slide for fertility in IBD. So we covered ulcerative colitis in the setting of surgery. We know that infertility risk is higher in the setting of surgery in the setting of ulcerative colitis. We also know that in the setting of Crohn's disease, women who undergo surgery for Crohn's disease, they have an increased risk for infertility as well. And then I really want to emphasize the right column, which is the no surgery piece. We also know that women who have IBD, both Crohn's disease and ulcerative colitis, are at increased risk for infertility in the setting of active disease. So minimizing disease activity is very important in maximizing fertility. And I can't emphasize that enough. I do also want to emphasize that if you have IBD and you're interested in getting pregnant, 6 months of attempted conception is how long we generally give a woman before we refer her to a fertility clinic, because we know that there is an increased risk for infertility in IBD. And so 6 months is kind of the duration of time that we typically give a woman. If the woman is 40 years or older, remember that age piece that I emphasized, then we actually refer after 4 months. Now, what about assisted reproductive technology? In the setting of surgery for Crohn's disease, we know that assisted reproductive technology is not as effective as it is for the general population. But the good news is that it is equally effective in people who have Crohn's disease who have not had surgery, and those who have ulcerative colitis who have not undergone the rectal dissection that I previously mentioned. And then when you look at patients who have ulcerative colitis who have not undergone surgery, I generally counsel my patients by saying that their outcome in assisted reproductive technology is comparable to that of the general population, although the data is a little bit more mixed on that. And again, I want to emphasize the importance of referring to a fertility specialist early. Okay, so before we move on to pregnancy, any questions about fertility? Okay. All right, so let's move on to pregnancy. Okay, so what can a woman expect if she has IBD in the setting of pregnancy? So this is a study that was done across 12 European centers looking at women who have IBD who are pregnant between 2003 and 2006. And there was a control group of women who have IBD who were not pregnant. And the finding was pretty interesting. So in the top figure, it refers to ulcerative colitis. So they found that there was about a 30% chance of flaring if you are pregnant with ulcerative colitis, regardless of your disease activity at conception. Whereas with Crohn's disease, it was different. Women who have Crohn's disease tend to do well if they enter pregnancy in remission and tend to flare if they have active disease at conception. So it seems like active disease is certainly driving the risk for further active disease in pregnancy. This concept of active disease at the time of conception driving further activity during pregnancy was also confirmed in this study from the Netherlands, from a city called Rotterdam. They retrospectively reviewed patients who went through a specialized IBD pregnancy clinic. They looked at 298 pregnancies and 229 IBD patients, and they found that active disease at conception was associated with disease relapse during pregnancy. Those patients were almost 8 times more likely to have active disease during pregnancy if they entered pregnancy with active disease. So, how do we prevent active disease? And the answer is preconception care. Is talking to your IBD physician about your interest in getting pregnant, if that's in your plans, early, and that's how you maximize best outcomes. So this is on the left side. This is a table from the same group from Rotterdam, analyzing their IBD pregnancy clinic that I mentioned before. And they found that women who underwent preconception counseling, women who talked to their IBD physicians about their plans to get pregnant, had better pregnancy outcomes. They were less likely to experience active disease during pregnancy. They were less likely to discontinue IBD medications during pregnancy. They were more likely to stop smoking, and they were more likely to take folic acid. So we know that preconception counseling has a very positive impact on disease activity and pregnancy outcomes in women who have IBD. And then there was another study that was a cross-sectional questionnaire study across 8 Mediterranean centers. And they found that educating women had a direct effect on the number of pregnancies and had an inverse relationship with voluntary childlessness. So after talking to their doctors about pregnancy, women were more likely to get pregnant and were less likely to choose childlessness. So it's no wonder that the North American guideline says that all women of reproductive age with IBD should receive preconception counseling to improve pregnancy outcomes. And so this is a message that I strongly convey to my IBD colleagues, right? Talk to your patients about the importance of reproductive health and about family planning as early as possible. And I also counsel you about this. Take the matter into your own hands. Talk to your physician, talk to your gastroenterologist, talk to your IBD physician about whether or not you want to get pregnant, just so that you get all of the information up front and so you can make the most informed decision for yourself. And actually, just recently, about a week ago, the European guidelines came out with the same exact recommendation, saying that preconception counseling is absolutely critical for all women of reproductive age. So when it comes to pregnancy-related outcomes in IBD, we know that women with IBD are more likely to deliver via C-section versus natural vaginal birth. They're more likely to experience gestational diabetes and to experience preterm, pre-labor rupture of membranes. Why is this the case? Well, we can't really run a causative analysis and say absolutely, X caused all of this, but it seems that most of the data are pointing towards active disease. So women who have active disease, we are seeing these outcomes a lot more often in those women compared to women who don't have active disease during pregnancy. And we also know that active disease is associated with miscarriages and preterm birth. So when you initiate the conversation with your IBD doctor about pregnancy, what kind of steps should be taken? So disease management is really important. We talked about active disease. We want to make sure that you have been off of steroids for at least 3 months and that you're in deep remission, meaning endoscopically there's no evidence of disease, and clinically you're feeling pretty much perfect, okay? We want to make sure that we address the fertility piece, which I mentioned earlier. It's important to get other doctors on board. The maternal fetal medicine specialist, the obstetrician, and even maybe the pediatrician. And then if there's a history of surgery, it's good to get the colorectal surgeon on board as well. Medication management is a big piece of preconception counseling, and I'll get into that in future slides. And then this is also a good time to talk about healthcare maintenance. Are you up to date in terms of your screening colonoscopy for colon cancer? Are you up to date with your vaccines? This is the kind of stuff that's going to have to be put on hold when you're pregnant. So it's good to address that before pregnancy occurs and just kind of tee you up from that standpoint. So at the University of Minnesota, I work closely with the maternal fetal medicine experts, and we have come up with a protocol for women who have IBD who are pregnant. And we stratify our recommendations based on the level of disease activity. So women who are considered to have mild disease get ultrasounds at 18 to 20 weeks and then growth ultrasounds at 28 and 34 weeks. And then we say consider delivery at 39 weeks. Women who have moderate or severe disease, we recommend more frequent monitoring in terms of ultrasounds, and we recommend a delivery at 39 weeks. So what if a patient is pregnant and she experiences symptoms? What tools do we have to actually work up that disease and get more information on what's going on? So the tools that we use, whether that's blood work or other things, we need to interpret in the context of pregnancy, because we know that pregnancy can actually affect our laboratory values. So in the setting of pregnancy, it's normal for hemoglobin to go down, platelets to go down, iron stores to go down, albumin to go down. It's normal for sedimentation rate to go up and CRP, C-reactive protein, to go up as well, in addition to white count. So need to make sure that in the context of pregnancy, we're actually interpreting our laboratory values correctly. Fecal calprotectin, which I'll mention later, is a really great way to monitor and screen for active disease in pregnancy. Fecal calprotectin is a stool study that looks at evidence of active disease in the gut. Imaging can be used, especially in the setting of Crohn's disease, where you can't really rely on other markers. An MRI scan and ultrasound are the preferred imaging modalities over a CAT scan, because those do not lead to any radiation exposure. And then if endoscopy is needed, then that can be done safely. There just needs to be a higher level of monitoring in terms of making sure that there is no evidence of contractions and that the fetal heart rate is okay. But if you need a colonoscopy, then it can be safely done during pregnancy. So let's move into medications. Steroids are overall considered to be safe in pregnancy if needed. You don't want to be on long-term steroids whether you're pregnant or not. But if you need a Band-Aid to help treat some active disease during pregnancy, that is okay. Back in the early 2000s, there were some concerns about cleft lip and cleft palate formation with in utero exposure to steroids. That has largely been debunked, although we just need larger data sets than what we have to definitively debunk it. So steroid use has been associated with some adverse events, in pregnancy. And they're listed here for you: the preterm birth, low birth weight, NICU admission, serious infections. I think that most of these are due to the active disease that the steroids are being prescribed to treat, as opposed to the steroid effect itself. And you just can't tease out the two from each other. They are way too intertwined to tease that out. But again, that goes back to the role of disease activity and how important it is to control disease activity before and during pregnancy. Mesalamine medications that you take orally, usually for ulcerative colitis. These medications are absolutely safe. We have plenty of data saying that it's okay to continue throughout pregnancy. Thiopurines, azathioprine, or 6-mercaptopurine, 6-MP, Imuran, all the same stuff. have been studied pretty extensively. The Piano Registry is the largest US-based registry of IBD women who are pregnant, looked at 242 exposures and found no increased risk for pregnancy-related complications or infant-related complications. The French National Health Data System looked at the safety of thiopurines in more than 3,000 women, and did report an increased risk for stillbirth, as well as C-section and preterm birth, and large for gestational age. But again, something that we need to keep in mind here is the role of disease activity, which they could not assess retrospectively in this really large database cohort. So it's a possibility that these findings are more due to uncontrolled disease. Biologics are safe in pregnancy. Again, going back to the Piano study, more than 800 pregnant women exposed to biologics were studied, and no difference in terms of pregnancy complications, except there was an increased risk for C-section. But again, that was probably more elective based. A large meta-analysis looking at more than 7,000 pregnancies with biologics found no increased risk for early pregnancy loss, preterm birth, stillbirth, low birth weight, congenital malformations. I personally have many women who have IBD who are pregnant, who I continue biologics in, or I even start a new biologic in pregnancy if needed, and I continue through the third trimester, and the outcomes have been great. Now, what about outcomes in children? We know that children who are exposed to biologics in utero do well. There's no increased risk for infections, hospitalizations, or any other adverse events. These children have been followed through up to the 5 years of age. We've also looked at risks of infections in kids who then attend daycare, and we found no difference in terms of infection rates among those who were exposed to biologics in utero versus those who haven't. Now, small molecules, we heard about these small molecules in the general session earlier today. We do know that they transfer across the placenta, and we do not recommend pregnancy in the setting of JAK inhibitors or the S1P receptor modulators. So the examples of the JAK inhibitors are tofacitinib, upadacitinib. S1 receptor modulator refers to ozanimod. Ozanimod specifically has a long half-life, and so we recommend being off of ozanimod for a good 3 months prior to conception. One other thing, speaking of medications that need to be avoided in pregnancy, methotrexate needs to be avoided in pregnancy. And again, that was mentioned earlier today, need to be off of that for 3 months prior to conception. So the bottom line is, when you think about whether you should be on medications for IBD in the setting of pregnancy, you have to keep in mind the other end of the scale, and that's the risk of active disease. We know that active disease poses a real threat to mom and baby. And we know that it's active disease and not active medications that lead to poor outcomes. So the general bottom line is that IBD medications are generally safe to continue in pregnancy. There are some exceptions, but when you get pregnant, it's not like you're walking on a tightrope, holding your breath for 9.5 months, just hoping to get to the other side. We can use our entire armamentarium in order to keep you and baby safe and healthy. When it comes to mode of delivery, there are just a few situations where we recommend elective C-section, and that's in the setting of a prior rectovaginal fistula or active perianal disease. You can imagine why we make that recommendation. With a vaginal delivery, you just don't want to upset things down there. And then in the setting of a pouch, it's kind of like a joint decision. Do we want to preserve that anal sphincter and so move towards a C-section? But if a woman wants to do a vaginal delivery, I think that's okay, just as long as there's a lower threshold to convert to a C-section if things aren't progressing. Breastfeeding, the mesalamines are safe, biologics are safe, thiopurines are safe. Methotrexate is not safe just because of lack of data. And then again, small molecules we do know transfer across the placenta and into the breast milk, and so we don't recommend breastfeeding on those. Just kind of want to remind everyone that we do know that mental health is an important aspect to postpartum care in everyone, but that's especially true in women who have IBD, because women who have IBD are at especially increased risk for mood and anxiety disorders, substance use disorders, and so having a connection with a mental health provider is especially important. Vaccines. Infants who have exposure to biologics in utero should not receive live vaccines during the first 6 to 12 months of life. And in the US, that just really refers to the rotavirus vaccine, and that should just be skipped altogether. So in summary, infertility increases after pouch surgery, Crohn surgery, and in the setting of active disease. Before conception, it's really important to be in a deep remission. Active disease is the biggest threat to mom and baby, not medications. Most of the time, vaginal delivery is safe, with a few caveats in the setting of perianal disease, where we recommend elective C-section. You don't want to be on methotrexate or any of the small molecules during pregnancy or in the setting of breastfeeding. And it is okay to be on biologics and safely breastfeed. And then just wanted to mention that I do have a multidisciplinary clinic with a maternal fetal medicine specialist at the University of Minnesota, where we see women who have IBD who want to get pregnant or who are pregnant, and we provide a unified message about how to have a safe pregnancy. That's it.